Hi, everyone. Welcome to our podcast again today. Today, I am actually interviewing a alumnus, a longtime friend that we've interviewed years and years ago and have interviewed over the years. And as I was thinking about guests for this year, I thought I should go back to some of my favorites from the past. So, Dennis, thanks for joining us today. Dennis is the System Vice President of Strategy and Planning for UW Health. Welcome, Dennis.
Hi, Stuart. Thank you for having me back.
Yes, of course. So today, I'd like to start off just by, if you could, because our listeners may not remember from the last time you and I have interviewed, plus your career has changed quite a bit. I mean, the world has changed a lot since then. So tell me about your current role at UW Health and catch us up on what you're doing these days.
So I came to University of Wisconsin Health here in Madison 2.5 years ago. System Vice President for Strategy and Planning. Our strategy office has responsibility for obviously the strategic plan, as well as business planning, the system portfolio and portfolio management, and then business development functions. My area is really focused on the strategy, planning, and portfolio side of the strategy office. So identifying the priorities for the organization, guiding the organization through the strategy process, prioritization of initiatives, and getting the work into the system portfolio and the planning necessary to determine, what resources will be required and how to deploy those resources.
So that is I think, very exciting and interesting job these days, right? Healthcare is changing so much and so fast. I
It's a
think
challenging job these days. It is exciting, but it's also challenging. A, a lot of academic systems, UW is not unique in this, are overwhelmed right now, with patients because of the impact of other factors in the environment, in the broader environment. So yeah, it's an interesting place these days.
so. I want to dive right into that in just a moment, but tell us about help catch us up on the size of UW Health and some of the, um, you know, do you have own clinics? Is it all academic? Like a little bit more about the extended platform of providers, so I have nowhere to start.
Yeah, so we're based here in Madison, Wisconsin, affiliated with the University of Wisconsin, obviously, and the academic health system here. We are about around a $6 billion enterprise. We have 3 hospitals in Madison that we own and operate: University Hospital, American Family Children's Hospital, and East Madison Hospital. We also operate another hospital through a JOA with Unity Point Health, the Meriter Hospital. And then we own a small community-based hospital system in Northern Illinois, just about an hour south of us, northwestern Illinois, in Rockford. UW Health Northern Illinois is our division down there. So we really have 2 core markets, and then we have a broad array of clinics throughout the region, mostly in Wisconsin, but not exclusively, also in Northern Illinois.
Got it. Okay, that's about what I thought. So let's talk about some of those challenges. I think the central issue we're going to talk about today is access, and I think you used the word overwhelmed a moment ago. Give us a sense of some of the challenges you guys are facing today.
Yeah, I think it's a significant number of factors that have created the situation that we are in and some other systems are in. The coming out of the pandemic, we were heading into the pandemic with a oncoming shortage of healthcare providers anyway, due to the talent cliff that we were hitting with retiring baby boomers and the fact that as a broad system, we weren't producing enough to replace all of them.
Yep.
The pandemic certainly accelerated that to a certain extent by pushing some people to early retire or to leave healthcare, because it was a rough time to be a healthcare provider.
Sure.
And some of the challenges that were laid bare in the pandemic didn't go away. as the pandemic kind of eased through. So the challenges that rural health systems have faced financially and with lack of providers, which has contributed to their financial challenges, has really put a strain on a lot of larger systems. Um, the rural systems, a lot are closing or having to close services, and those patients have to go somewhere. Not all rural hospitals are an attractive, acquisition for larger systems because of the cost involved. So, I mean, we've had systems that are hospitals that have closed in our region that, people ask us, well, why don't you guys just take them over? And in some cases, it's a situation of declining population, deferred maintenance, debt, whatever the combination is. Not all rural hospitals are doing well, and not all rural hospitals are necessarily an attractive acquisition for a larger system. But those patients still need and deserve care. And so the question is, how do you support those environments and those patients without them all having to come to, into the larger systems? So for us, it has resulted in a really significant increase in demand. And we're struggling, honestly, to meet all of that demand. And so a lot of our strategies have been focused on how do we create opportunities to deliver care? How do we improve access and deliver the care to everyone who needs it?
That totally makes sense. I mean, the challenge in rural healthcare is, big and looming. And it's interesting, Dennis, we worked a little while with, I'm not sure if you guys cooperate with them or not, but Homeward, their idea was, as a new venture capital-based company, was to deliver sort of house calls through, mostly nurse practitioners and PAs. Whether it's them or any other model, do you see that as a viable option moving forward with companies or just within your own system to try to bring, house calls out before people get sicker? I don't know if that's it. I see.
Our approach right now is everything is on the table for consideration in terms of every possible delivery method. So that's going to include virtual, in-home, and, in person. And it's got to also include, for every type of service we need to offer, we ask ourselves, is this something we build ourselves? Is this something we buy from someone, or is this something we do in partnership with someone? Yeah. And so we have to consider all options because, I think it's unrealistic for any system, even the big ones, to be able to just say we can do this all ourselves.
Yeah, there's so much out there, right? I mean, again, you're not alone with this problem, and you guys are a respected institution. It is interesting what you just said about I can certainly see that not every localized hospital is a good one, right? To be able to just sort of pick up. And that brings, even if you did, the administrative and the management and all those things are real, right? So if it's a hospital, it's real. Well, so the idea, some other models that, when I'm talking to smart people like you that come up, obviously telehealth has some promise in some ways. And certainly, when I think back about, these, because I don't know if you know this about me, Dennis, but, for years I was on the road teaching, marketing to practitioners, including people in rural areas. And the idea,
I remember that now.
Yeah. So you come in for a surgery, and then you have to come back for follow-up and drive 4 more hours of whatever. So for routine stuff, I think telehealth is going to work. Not everybody's, embracing it, as we know. You also have remote patient monitoring. And, we talked about house calls, other models. I'm curious, going back to the telehealth and the remote monitoring, is that taking a bite out of the problem? I mean, I think as you guys go forward, I'm guessing it is helping, but it's not enough. But I'm curious what you think.
It is helping, and it's going to help more and more as both we get better at it as a system, and as the broader health system gets better at dealing with it in terms of payment models and that sort of thing. It is a practice shift, but it's also a operational and financial shift to manage. So,
continue. I'm sorry.
For your example of, you have a surgery and you need a follow-up, do you really have to drive that, 3 or 4 hours, like you said, back to have the surgeon do it? Or could you go to your primary care provider, and your primary care provider has received information from the surgeon and knows what to check for, or you have a virtual consult while you're in your primary care doctor with the surgeon and your primary care doctor to say, this is what we're looking for. How is the patient doing with X, Y, and Z? And let that patient do it in their home community. There's things like that. The remote patient monitoring is certainly helpful. It's best when it seems to be best utilized when it's tied to something like home health, and it's most effective in like hospital at home, sniff at home kind of situations. But we have to get better and better at how does that information from the remote patient monitoring, devices, how is it used, how is it acted upon, how does it drive care improvement?
Yeah, I can see the infrastructure of all this, right? All that data is going around. How do you manage it? How does that fit with everything else you do? And oh, by the way, your doctors are all very, very busy as it is. So
Yeah,
you're kind of like fixing the plane while it's flying, right? You've got
absolutely. And
this.
for things like, hospital at home, for example, which is really a great option for some people. But for most hospital at home, programs, the patient has to live within a certain distance, can't live beyond a certain distance from the hospital, because if things go south, they will need to get in, be admitted, get into the hospital. And so, there's all sorts of challenges around extending these into rural environments in particular.
Do you feel like, it's funny, I've been the whole AI, which is the topic of every conference I go to lately. But I haven't dug into this very deeply, that there are some pilots going around where AI really is doing a good job of diagnosing and being able to be a part of the team. And if we're thinking about extending care, and I talk about this to sort of, non-healthcare friends, what's going on in healthcare? It's like, well, you have NPs and PAs and you have doctor shortages and you have this and that. But do you feel like AI, if it's not ready yet because of a whole bunch of issues, including, safety and, the lack of being proven and reimbursement and all that, but can that be part of the solution for routine stuff to help identify, to be
I think
part
it's going to have to be. I think as those algorithms get more
of?
efficient and more reliable, they're actually already pretty reliable, and they do really help physicians diagnose more quickly and more accurately. And I think that we're going to see huge advancements in the coming years as this continues to develop. Right now, if you think about it, a physician, you go get an MRI and you get a lab report, and those go as separate reports into your medical record, and the doctor has to look at both and kind of try and, piece it together. I could see a point in the not too distant future where those kind of reports and tests all come into an AI tool that looks for different patterns and then makes recommendations to a physician in terms of what a likely diagnosis would be, or what a likely, appropriate treatment pathway would be.
Yeah, that's exciting because, we're all still humans and everybody's busy and there are biases, right? People may miss something. And so the idea of at least, I feel much more comfortable if I'm going through this process as a patient that the doctor is still in charge, is still
Yeah.
quarterbacking, but using the tools, then I feel actually maybe better, right?
I
'Cause-
think I think I don't see us getting to the point where AI is doing the diagnosis and treatment plans independently.
right.
But I think that they can make physicians significantly more efficient and take workload off of the physicians, where the physicians are looking at the recommendations from the AI and kind of saying, does this seem to fit with what I've seen in the patient? And then moving forward from there.
Yeah, I mean it's interesting because going back to pandemic, when, healthcare, as we know, Dennis, isn't famous for being moving fast and coordinating. So
Right.
but during pandemic, we suddenly telehealth went from like, we can't do it and all the reasons why we can't do it and all the reason why it won't work to all of a sudden everybody's doing telehealth in a matter of weeks, seeing
Yeah.
of millions of patients. And so this side of it, I'm curious, there is not that singular event of a pandemic forcing change, which just there is no other alternative, right? But with the AI and some of these other things we're talking about, I feel like the demand is going to be so overwhelming that it just has to work. Like they'll have to
Exactly.
think about, you know, so
Yeah.
that's
And
important.
we know that American healthcare is too expensive, hard to get into, and frustrating for patients. I mean, it is, and it's unfortunate. We've got to find ways to make it possible for people to access care more efficiently and at a lower cost.
So
And
I,
for those patients for whom active management is necessary, to identify them earlier and provide them support in an efficient way again. And that's where all of these tools are going to become the most helpful, is identifying a patient who's at rising risk before they become a total clinical train wreck. And to better manage those costs and their health and their well-being.
so let's talk about that a little bit. The idea of value-based care and what you just said, when we start looking at value-based care or more broadly on the population side, population health, like how do we keep people out of the hospital? And this is a classic area thing in rural healthcare, right? You have people that it's hard to get care anyway, and not everybody is, super inclined to take care of their health.
Yeah.
So, how does that change? Like, how can you do that? What are you guys finding is working? Like, and is it grassroots? Is it email? Is it mailings? Is it just making sure your doctors are talking about this to patients when they see them? Because that's a huge challenge. And I'm curious, like, what steps can you guys take to help on that?
Yeah. So in our current strategy, we have three key areas. We call them our strategic imperatives. And one of them is value creating care. And we intentionally made the choice of not saying value-based care. And that's because value-based care is a payment model. It's not a care model. It's not patient focused. It's how do I get reimbursed focused, right? It's payment focused. So for us, we wanted to think of it in terms of value creation. And value creating care is about what is the value to the patient, what is the value to the the payer, and what is the value to those involved in delivering the care. Because I think if you focus solely on the payment model, it's not going to work. What we have to do is and your question was really about how do we engage the patients,
Right.
right? So how do we identify when, in terms of providing people with care that is appropriate for where they are in their life and what they need. If you're a 20 something, 30 something year old who's healthy and doesn't need to see a doctor regularly, doesn't have, significant medical concerns, how do we provide you with the care and the information that helps you identify when you do need to see a doctor? And do you need a specific primary care provider that's your person, or do you just need to be able to get access from your care system and know that if there's something that triggers a rising risk concern, that then you will get assigned somebody to help you manage that? And it may not have to be a physician. It could be an NP. It could be a nurse. It could be a pharmacist. It could be a nutritionist. It could be lots of things depending on what it is you're at risk for. So how do we help get people to get the preventive care and the uh, minor acute care that they need in an efficient way that builds trust and also keeps costs down? And so it's,
Great.
it's really around value creation. It's creating multiple care models that a patient can travel through based on their individual need.
That's fascinating. And it's really interesting you said nutritionist there. So you have lifelong habits that are forming in your 20s. So even then, it's a lot easier to take care of things for you avoid obesity and diabetes, through life planning than elsewhere. What?
And it's about delivering care differently than we used to. You hurt yourself, playing football on the weekend, or whatever. And in the past, you'd go to the orthopedic surgeon, right? Well,
Yep.
surgeons are really expensive, and most of the time you don't need surgery. So
Right.
maybe you should go see a physical therapist first for any musculoskeletal stuff, unless it's an obvious break or whatever, right?
Right.
Um,
So go ahead. I'm sorry.
and it's the same sort of thing when you're thinking about just even general concerns. You have a rash that pops up. Do you really need to see a dermatologist, or can you take a picture of it and send it to your primary care provider who has most dermatology is visual. So a lot of that can be done virtually, and it can be done asynchronously or, live. There's a lot of different ways we can deliver care now with the technology and stuff that we have that is far more efficient than the way we've quote unquote always done it.
So that's
And that doesn't have to be less personal. People think it's not personal. It can still be personal.
so I love that resourcefulness you just mentioned. So for example, the PTs, with direct access states where people can go to a PT directly versus having to get a script. And then, here in California now, I believe everybody has to be a DPT, director of physical or a doctor of physical therapy. But that's something that, taking advantage of the PT network out there is a way of expanding, and that's resourceful. I'm curious uh, how can you integrate, and I'm assuming this is a priority for you, but I don't know, the local primary care providers that are out in the countryside? Like, do you guys have formal programs? And as you start reimagining healthcare with them, are you trying to engage them? And I'm assuming some are more engaged than others. Some, want to just keep doing the same stuff they've always done. But tell us about that.
Yeah, we tend to work more with either larger practices or hospitals throughout the region than want to go individual physicians. But what we really try and do is, as an academic medical center, say, how can we best support your practice, um, so that your patients don't have to leave your practice and your town and your system to receive the majority of their care? So is that through providing provider to provider consults as needed? Is it through, supporting that local hospital with EICU support, that sort of thing? Sometimes we send physicians out in the old-fashioned outreach clinic kind of model still too, but only in those situations where it really makes sense, both for the provider that we're sending there and the community, with their need.
So that makes sense. So going back to engaging patients, some people are, much more sort of self-advocating than others. Some people would be if they knew how to. Some people don't know how. Some people don't really care. Have you found any secret sauce here, or is it just a lot of work? Like, how do you get people to engage, um, you know, um, or what are some of the big challenges you've seen? And maybe it's just inertia. They're used to doing things a certain way.
I think the only secret sauce is giving lots of options and helping people to understand what those options are and why they might select them. I think Kaiser actually does this really well, where if you call for an appointment, they say, well, I can get you a virtual care. I can get you a virtual care, depending on your what you're calling for, right? But if it's an appropriate condition, they'll say, I can get you virtual care today. I can get you in with an APP next week, and I can get you in with a doctor in a month and a half. And here's the price difference between them. Which one do you want, right? So healthcare has never been good about giving patients the information to be more engaged and take more ownership of of their health. Healthcare traditionally has been I'm the expert. I will tell you how this should be done, more than let me engage you in giving you information and so that you can make a decision about how you're cared for.
That makes sense. And that is overdue, but awesome. I can see how that would work really well. The another question I would have, going back to something else you said a few minutes ago, like bringing other options, for example, seeing the PT, you have the patients to educate them, but the doctors also that, especially if they're in a private practice, have been doing a certain things a certain way for a long time. Even if they want to cooperate, there's habits, right?
Yeah.
So, right, they just used to always
Yeah.
doing this happens and I do that. They don't even think about it because it's just so natural. So, as you guys think about the future, are there ways of just continually educating doctors at scale, whether they're in your network or out, to help just reinforce some of these new ideas? Because I could see it's like even if they want to participate, we're all human. It's like easy just to do the same thing we've always done.
Yeah, and physicians are incredibly busy too, but physicians want to be practicing at the top of their license. They want healthcare providers generally want to be more at the top of their license. They want to be efficient. They don't want to be seeing patients they don't need to see. A surgeon doesn't, an orthopedic surgeon doesn't want to see 10 patients who don't need his services and then say, well, all you need is physical therapy or all you need is that. They don't want to do that. They do it
Well, that
because
makes sense.
that's what they've done in the past. But if you give them a way that says, we're going to take that off your plate, I am I can't think of a time when I've had a physician say, no, I want to keep doing it the way I have, when you give them a really genuinely useful option.
This is such an insightful call because I'm just thinking back to all the doctors I've worked with in the past. And the idea that, okay, this is what you're really, especially today when they're feeling like I'm an administrator, I don't want to be an administrator, but
Right.
even clinically, right, to be able to say, okay, I'm a surgeon. I remember once I was just a specific doctor and he's like, no, I'm a surgeon. I do surgery. He didn't want to do this other stuff. And so, or, a classic case of, I remember high maintenance, emotionally patients, and the doctor admitting to me, like, I don't want those patients. And it's like, okay, instead of trying to not a bad fit for both sides, get, psychological care or whatever to be
Right.
part of the equation, and it makes sense. Let's
Well,
talk.
that's another great example because behavioral health, mental health is an area that we have a problem with in the United States. We don't have enough providers. There's incredible demand, and what we did here is we have embedded behavioral health, mental health providers within all of our primary care settings. And if you come in for any kind of a primary care appointment, virtual or in person, we do a quick screening. And if you get a certain score, the provider you're talking with, whether it's an NP or a physician, you know, can probe and say, would you seem to be experiencing a lot of anxiety? Is that something you'd like some help with? And we can get them connected with primary care, with behavioral health, mental health, in that same visit to initiate an intervention, a short-term intervention, because a lot of people just need help getting over a hump, or then in some cases, the mental health provider identifies a more significant issue. But that kind of thing also takes a load. Yes, we're asking them to initiate the conversation, but it does actually take a load off of the primary care provider, um, to know that that resource is available right there.
That's great. And I would assume you have in your communities a fair number of Medicare patients, a fair number of Medicaid and dual eligible. Anything specific you've learned about, how to service those populations well, and how is that evolving?
You know, for the Medicaid or Medicare, sorry.
Well, I would say both, really. It's like
Yeah.
like you can take one at a time to make it easy.
For the Medicare population, the growth in Medicare Advantage plans, which are likely going to expand even more here in the coming years, I think, it's really about proactive management and ensuring that you get them in, comprehensive annual wellness exams, that sort of thing, and making sure that that you're able to uh, connect them with a team of people. And again, this is about educating the patient that you don't always have to see Dr. Jones, because Dr. Jones has there are all these people in Dr. Jones' office who work with him to support you. So maybe what you need is a regular check-in with the pharmacist. Maybe what you need is a regular check-in with the nutritionist. Maybe what you need is a regular check-in from home health, or that sort of thing. We've also expanded our primary care at home model for those patients for whom leaving the home is challenging, to make it possible so that they can receive primary care visits in the home. And that's pretty important for that population as well. Medicaid, it's really around access and ensuring that they're getting the care, because most of the individuals on Medicaid, there's a reason for them needing, being on Medicaid and needing those services. And so identifying, how we can best reach out to them, it's a challenge. I honestly, I don't have a single answer to that question, but
For sure.
certainly getting them to engage with you in that just annual kind of checkup, is key, because that's
That
the
makes
part that flows, that everything else flows from.
So we've talked today about a lot of things. And access is the key issue, of course, for the things you're facing. Are there any services that you still want to do more of? Are there any services that you don't have enough access, or you have access that you feel like can really help, or is that just such a second priority you guys aren't thinking about it these days?
No, we are. I mean, certainly, as an academic medical center, we're continuing to push the boundaries and trying to think about what's next. And we are certainly leaders in a number of areas. For us, oncology and solid organ transplant, neurosciences. There are a number of areas like that we continue to lead in, and that we have a responsibility to really provide, the higher level services for the entire region. And so we continue to push in those areas. And we just, continue to advance the field. In some of the, quote unquote ancillary areas. Our physicians don't like it when we use that term, but in imaging, advancing imaging and pathology, like I said, those are kind of integrating, how we're thinking about next generation therapeutics, the biologics, cell therapies, gene therapies, those sorts of things are certainly critical as well. So we're not dialing back. Because of the access crunch, we actually think some of those things are going to be critical to how we provide access in the future.
That makes sense. So, a couple questions more before we wrap up. I'm curious, just from the marketing standpoint, because this is a different kind of a situation you've been in the past, right? So, broadly speaking, you don't have to share everything about your marketing plan, but like, how does a system like yours, market to patients, market to doctors, and how does that evolving and changing over time?
Yeah, ironically, I had like my monthly check-in with our chief marketing officer just immediately before this call. For us, it's all around that personalization. It's about using technology like a CRM to extend the personalization of the care that we're trying to provide, and translating that into the information that the patient receives. It's not, we used to 15, 20 years ago, you'd, do a newsletter or a magazine or something that just everybody got the same thing. And now we don't do that. We really target the messaging around ways that, how to promote prevention, self-care, and helping patients know when they should engage with us based on their own profile.
Outstanding. Anything we should have talked about today? This is a lot. This has been just as fun and insightful as I knew it would be. But anything you think we should be talking about that, maybe about where healthcare is and where you guys are going from a strategic level?
I think it's going to be a very interesting decade ahead of us in healthcare. We've got to get access, affordability, both kind of under control at a systemic level. And don't mean UW health system. I mean, national system. I think each system, each each of us is trying to new things and continuing to learn and share through, venues like this and others, is really important because we have to continue to get better at this. It's necessary for the health of the country and the individual patients and the health of our systems.
So it's interesting that you had another insight I loved, which is, I think reimbursement drives this so much that sometimes we don't even see it,
Yeah.
how it's being thought of from a reimbursement viewpoint. And healthcare has had its challenges, and certainly recently, but, for the last, X number of years, increasing sort of I guess, the pressure. And one thing that I've always talked about for years is that, nobody would design the system that we have today from scratch like this, right? Nobody would just say, let's do this.
Yeah.
Let's go whiteboard how it's all going to work.
Yeah, it's the most Rube Goldberg of all systems in our country,
So how do you, it's really difficult because nobody likes it, but then everybody has an interest for the way it is, right? So it's really difficult to make substantive change, but I feel like the pressure is so much that we'll just have to figure it out now. It's like,
yeah,
or
exactly.
That's really hard.
Exactly. And there are some really, really good bright spots out there too. There's a lot of challenges, but there are a lot of really good people in healthcare across this country and good organizations who are trying new things and who are making really good progress in, improving care and improving efficiency. And that's why I think sharing those lessons learned so that people can try it in their community and see what works, because every community is a little bit different, but a lot of the principles are pretty broadly applicable.
Great. Dennis, great job today, as I expected. It's been really fun reconnecting.
Excellent to talk to you again.
Yeah, I invite you anytime you have some news you want to share that you think is helpful to, the broader audience. You're always welcome back. So think of us as, part of your, one more microphone for you to get the word out. I appreciate it. Thank you so much.
Thank you. Great to talk to you.
Great. All right, Dennis, we'll cut this part out. It was great. I really enjoyed it. It was so much.
Me too.
It was so much fun to hear your point of view, and all the challenges that you guys have. And it's such see such different clients with different issues. But anyway, so it was great. So I will, as I predicted, you did great. We will send a summary of the call, which, by the way, talking about AI, we've been using Fathom lately to help my writer organize this, and it's been fantastic.
Yeah. I mean, we do a lot of we have a lot of our primary care physicians using the ambient listening. We have AI that drafts, my chart responses ahead of so that the provider just has to look at the drafted response based on what the patient asked and then can modify it. And those things really are helping with efficiency.
That's awesome. I'll leave with that thought is I make a living by listening to people, and there's stuff I miss all the time. I go back to the summary. It's like, oh my gosh, that was the next step I forgot. So anyway, great talking to you. Let's keep in touch. Super excited that people like you are helping. We need.
Certainly correct.
All right. Thank you. Take care.
Thanks. Have a good one.